friend, Dr. Ahmad Dian. Hello, Dr. Ahmad Dian.
Hello, Dr. Madhuri Mehta.
Good,
Nice to
Dr.
meet you
Ahmad
again.
Dian. Nice talking to you.
Yeah.
And I hope we'll definitely meet soon
Yes.
with this.
Yes.
So, Dr. Ahmad Dian will be the moderator for this first program of masterclass series of facial nerve. So, the story of how this program began goes all the way back to when Indonesian delegates first met Dr. Mehta at the facial nerve conference in Madrid last year.
Yes.
And she was incredibly welcoming and eager to share her expertise with Indonesian ENT surgeon. Surprisingly, she prepared for 7 series of the lecture on facial nerve.
Yes.
And so thank you so much for your time and dedication. We agree with all your lecture. So next, I will give time for Dr. Artono, the chairman of the Indonesian Otologi Study Group. Dr. Artono is an otologist and lecturer from Sutomo Hospital, Faculty of Medicine, Erlangga University in Surabaya, and he will deliver a welcome note for this webinar. Please screen for Dr. Artono.
Okay, thank you, Dr. Diana. Sorry, I'm off camera because I trip to Jakarta. I will visit Dr. Diana. Okay, good morning, distinguished speakers. Good evening, Dr.
Okay, you are
Madhuri
somewhere
Mehta.
where it is morning time, okay?
Yeah, okay.
So we're all in
Okay, on
different
behalf.
zones and enjoying the togetherness. That is great.
Okay, thank you. On behalf of the Indonesian Oncology Society, I would like to warmly welcome to you, Dr. Madhuri Mehta,
Thank you.
and to all these participation in the evening session. We are honored to have the Dr. Madhuri Mehta with us today, who will deliver a lecture on surgical anatomy and facial nerve week. And then thank you to Dr. Diana and Dr. Ahmad Dian as the moderator. We believe this topic will be very useful for our daily practice to ENT college in Indonesia. This event is part of the lecture series, and we are planning to continue with several more sessions in the future. We hope this serial lecture will provide continued learning and seamless collaboration among us, and especially with Dr. Madhuri Mehta from India. Thank you very much, Dr. Mehta and Dr. Diana.
Thank you, Dr. Artono. Safe trip. And now let's begin the main program with the first topic of the facial nerve lecture titled Surgical Anatomy of Facial Nerve. And Dr. Ahmadian is an otologist and lecturer from Saiful Anwar Hospital, Faculty of Medicine in Brawijaya University in Malang.
Okay.
So he will moderate this session. So please, Dr. Ahmadian, and to open this session with Dr. Madhuri Mehta.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Good evening. Thank you, Dr. Diana, Dr. Artono, and Dr. Madhuri Mehta, and also thank you for all participants. This evening, we will listen the lecture from the Dr. Madhuri Mehta with the title Surgical Anatomy for the Facial Nerve. This is important for us because as the ear surgeon, we always face or maybe deal with this problem with the facial nerve. So maybe brief information about Dr. Madhuri Mehta. Dr. Madhuri Mehta is a senior ENT specialist in Hisar Haryana. She also the director and head of the ENT department in Jindal Institute of Medical Science. So is it all right? Is it okay? Yes? Yeah, okay. Okay. Okay, so Dr. Madhuri Mehta also has many experience with ENT surgery, especially in the ear surgery and facial nerve. It's honor for us to attend this lecture. To all the participants, before we start the lecture, I remind to all the participants, please mute your microphone during the lecture. And if you have any question, you can chat in the box, chat box. You can write on there. And we have maybe 1 hour lecture for Dr. Mehta, and then we can discuss for the question. So please, Dr. Madhuri Mehta, you can start the lecture. Screen is yours.
Thank you, Dr. Ahmad, Dr. Artono, and Diana. It is really heartening to connect with you all. And I still remember the day. The world is so beautiful. I feel over the years as I grew up, I found the more I was receptive for good things, the more things started coming back to me. And suddenly you find some good people associating with you, and then you can prolong our togetherness for a very long time. And this is the start of one such relation. Diana has been very kind to have, given me this honor to share what I have to share with you all. The facial love has over the time become my passion. Let me first start share this presentation. Is it visible?
Yes, we can see. Yes.
Okay. So when I joined ENT, then not many women ENTs were there in our country who were joining. I was in the starting ones, and then I felt this is more of a ENT is a more of a feminine branch because such a fine and small things to be done. So over the years, when my liking for ENT became my passion, my obsession, I could know I am a painter at heart. I paint more and I was more interested in being an artist than a surgeon. But once I weaved them together, I could bring out good results. And facial love is one such thing where I find the artistry to protect every bit of the sheath, the fiber, the exon every possible thing. So for that, when I fell in love with facial love, I thought of going into the details and trying to start from the first exon to the bundle and how it behaves in body and how we can correct and manage it. So facial love anatomy is very important to be learnt, and its surgical relevance to protect it or to manage it once we take up a case of facial nerve. Never touch a facial nerve if we are not totally well versed with the things, and keep fine tuning your surgical acumen by doing temporal bone dissections. So if we take it up, this is my son. He is also a MS DNB ENT. He has joined me in from last 2 years. So this first lecture I have been preparing all the lectures, so he will start. He presented in the national forum this basic anatomy of the facial nerve. So I improvised it on. So I am thanking him because I took this lecture from him, a bit of it. Okay. So now coming to facial nerve, beautiful things don't ask for attention. They're always there. They catch our attention, and facial nerve is one such structure which is always there catching our attention. We have to be careful and receptive. Going to the history of facial nerve. In this is the picture of Charles Bells, the doctor, who was an artist as well as a surgeon. And he was not a very good surgeon. I have read about him. There were many mortalities when he operated on patient, but he was so artistically oriented. Then the War of Waterloo, he took up this victims of those wars. They have all the injuries on the face and neck, and then he started dissecting in them to know the anatomy of face. He got so much obsessed that he was taking up all the victims and doing all the experiments on them. And then he wrote this book, the chapter, The Nerve of the Face and Eye. And he drew many pictures and paintings of the facial nerve. He was the first one to tell us that the facial nerve existed. He told us he was in the 1800 early part of the 1800, and he gave this information to the world that there are sensory and motor nerve fibers. This is the facial nerve. This is not to be cut, because in the olden times, surgeons would cut the facial nerve to relieve for the neuralgia. He also gave us the Bell's phenomena, and we have named the Bell's palsy in his name. Then there is Leonardo da Vinci, who was a artist and painter par excellence. He painted this. He took almost 15 years to paint this Mona Lisa painting. And this is the most valued, prized painting, at the same time in most studied painting in the art piece in the world. But when I went through it and I read about it, that it came out that this lady was in the postpartum period, and she had suffered Bell's palsy. And this crooked smile is not her natural smile. That is the residual synkinesis. So this is something, I mean, it can be imaginary or true, we don't know, but I could remember two things out of it. One is in postpartum or pregnancy, last phase of pregnancy, Bell's palsy is more common. And if not treated, facial nerve is not, while it is recovering, it is not treated properly. Residual synkinesis can remain, and everybody may not be given this label of Mona Lisa smile. It may not look good on everyone. So we must take care of the facial nerve once it gets affected. Coming to the facial nerve introduction, it is the seventh cranial nerve, longest and the most tortuous one out of all the cranial nerves. It has 10,000 neurons, 7,000 myelinated and 3,000 non-myelinated. Myelinated are the motor ones and 3,000 non-myelinated are the somatosensory and secretomotor fibers, which are in the nervous intermedius root. So if we take up the four nuclei, the facial nerve has, one is motor, one is sensory, one is parasympathetic, one is special sensory. So how it goes about is, this is a mixed nerve, embryologically develops from second brachial arch. It has four types of fibers. One is general somatic, two afferent, two efferent. We have to remember that. Two general, two special. So these four, how we divide it? General somatic afferent, special visceral afferent. Then general somatic efferent and general visceral efferent. This purple one is the one which is general somatic efferent, is the main motor nerve. Rest all three are the smaller part of the facial nerve which are included in nervous intermedius. So all are organized into two roots. One is motor root, the facial nerve carries GSE. Rest three are included in nervous intermediates, which are GSS, SVA, and GVE. And GVE has got descending, this GVE, general visceral efferent parasympathetic secremotor fibers have descending fibers from the superior salivatory nucleus, and this GSA, SVE and GSA have got a ascending fiber from geniculate ganglia. What are the functions of different fibers? Now, considering general somatic efferent, they carry cutaneous sensations. And let me reduce it. They carry cutaneous sensation from skin over mastoid, lateral surface of pinna, extraocular canal, and demanic membrane, whereas special visceral efferent, we are talking about efferent. Those are the normal sensory fibers. These are the special sensory fibers. They carry taste information from the anterior two-thirds of the tongue. Then comes GSE, main motor nerve, which innervates the muscles of facial expression, scalp, which are the second pharyngeal arc product, the stapedial muscle, posterior belly of digastric, and stylohyoid muscle. Whereas GVE, the parasympathetic one, it innervates and supplies the lacrimal gland, the salivary glands, and the mucous membranes of the nasal cavity, and both hard and soft palates. So if we divide the function, it is one is GSE in the main motor root, and all three are into the nervous intermedius root. Coming to facial nerve segments, it has been divided into three parts: intracranial, intratemporal, and extratemporal. Coming to intracranial segment. Intracranial segment is again divided into supranuclear, nuclear, and infranuclear. We know very less about this part because usually as otologist and ENT, we come across the nerve which is the intratemporal and extratemporal. So it is important to know about it also. Coming to supranuclear, it can be it has got voluntary pathway and involuntary pathway. If we talk about the voluntary pathway, there is upper motor neuron which is located in the this motor cortex, primary motor cortex in the frontal lobe, precentral gyrus. So this is the area where the upper motor neuron lies. It goes down in the corticobulbar tract and goes through the internal capsule as a bundle and then reaches the pons. Pons there forms two roots, dorsal and ventral. The dorsal root supplies the bilateral input to the upper face, whereas the ventral bundle supplies contralateral input to the lower face. We have been reading since many years. So whenever there is a supranuclear lesion, then because there is a bilateral supply of the upper face, so upper face will be spared, but contralateral facial palsy will be there when there is a upper motor neuron lesion. If we talk about involuntary pathway, they are not very well understood over the years, though so many people have been trying, so many researches have happened, still they have not been able to find the proper how it works in our body. This involuntary pathway is basically laughing at a joke, getting frightened, feeling happy, crying, screaming. All these are natural things which come to us, like natural spontaneous emotion induced facial moments. These are the multisynaptic pathways connecting to different parts of the brain, and it involves the extrapyramidal system to produce the spontaneous emotional induced facial movements. So if I give, this is a video of a bilateral facial palsy. Now let me tell you about this patient. Over the years, when I started taking up facial nerve very seriously, I keep finding such different things, such different kind of patients of facial nerve, which are not even mentioned in the book. Now, look at this bilateral facial palsy. This was a case who was operated by me on the right side for the ear disease. He came to me with facial paralysis grade 4, left side with chronic SOM. I thought of operating this case, but we were planning to operate. Immediately, he had a complete facial palsy on both the sides, left vocal cord palsy, kidney, liver all started failing. I could not know what had happened. Finally, we have found out this case to be a Wegener's granuloma, and we are treating this patient. But if I showed you this video, if a patient of bilateral facial palsy comes to you, clinically, how we all are going to know whether it is upper motor neuron or the lower motor neuron lesion? Dr. Ahmad, can you guess it? Can you tell clinically a case of bilateral facial palsy, whether it is a upper motor neuron or a lower motor neuron lesion?
Maybe upper motor neuron.
Uh, Upper motor, why are you saying so? This is complete bilateral facial palsy.
See. Because the upper and lower, so maybe the lower motor neuron because complete.
So let me tell you, once a patient like this comes, when we tell him to do 7 volitional movements like raising the eyebrow, closing eyes, lifting the angle of mouth, he will not be able to do it. If it is a upper motor neuron, lower motor neuron, then if we crack a joke, if we upper motor neuron, if we crack a joke or show something that show his natural responses are there, that means it is upper motor neuron and not the lower, because the emotional part, involuntary pathway has been spared. So involuntary pathway is totally different from the voluntary pathway. Now coming to the nuclear segment. There are 4 nuclei there, as I've told you. Motor is the special visceral efferent. It has got descending fibers. And superior salivatory nucleus and lacrimatory nucleus, it has got general visceral efferent, has got descending. Both are descending fibers, and these both are ascending fibers. This is the nucleus of Tractor solitarius, which has got special visceral efferent ascending fibers from the anterior two-third of the tongue, and sensory GSA ascending fibers from the mastoid, extra-auditory canal, tympanic membrane, and pinna. So all 4 are located like this. This is the motor one, which goes around abducent. It has got efferent fibers to the muscles of the face and scalp. This is superior salivatory and lacrimatory nucleus. This is the parasympathetic supply. It takes the descending fibers to the lacrimal gland and the mucosa of the nose, paranasal sinus, palate, sublingual and submandibular glands. Whereas this nucleus of Tractor solitarius and sensory nucleus, this is sensory nucleus is for the anterior two-third of the tongue. So this is this, you know what, we keep reading these and they keep confusing us. You have to keep 4 things in mind. One is simple sensory, which it is getting from the pinna, extra-auditory canal, tip of the mastoid and tympanic membrane. Other is special sensory, which carries fibers from the anterior two-third of the taste fibers, anterior two-third of the tongue. And if we take up efferent fibers, there are 2 varieties. Efferent main motor supplies the muscles of the face, scalp, and this posterior belly of digastric and stylohyoid muscle. Whereas the special efferent are parasympathetic, which are supplying to the all the glands of the nose, palate, and this. So this is how you remember for 4 things. Coming to the infranuclear segment. This is what we call as CP angle, which is cisternal, also called as sexternal segment. It is 15 to 17 millimeter in length. Starts from the pontomedullary junction to the porus of interaortary meatus, which is the medial part of the interaortary meatus. This length is around 15 to 17 millimeter. The two segments of the facial nerve and nervus intermedius emerge slightly away from each other. Facial nerve exits the pontomedullary junction ventrolaterally, whereas nervus intermedius emerges at the lower border of the pons from here, close to the eighth nerve. So we take up the facial nerve. Now from here, kindly read these two important lines, because the uh, relationship of facial nerve with the eighth nerve is very important, because we are doing so many surgeries. We must know in the left skull base surgery how the facial nerve goes. The facial nerve lies lateral and rostral to the sixth abducent nerve. This is the abducent. Rostral means anterior. So it lies lateral and rostral to the sixth nerve, but medial and caudal, which is posterior to the eighth nerve. So at the exit from the brain, it lies medial and posterior to the eighth nerve. Here it is devoid of epineurium, but covered by pia mater and CSF as the layers of the brain. Surgical importance is in CP angle tumors, extra care for preserving the facial nerve is to be taken, as there is, because injury in this segment can cause loss of proximal stump of facial nerve for repair, and grafting will not be possible, and we will have to take another proximal stump, which can be fasciomesenteric or fasciohypoglossal or cross face anastomosis for the repair. So in CP angle, because epineurium is also not there, it is very delicate, easily injured, so we have to be very careful. Coming to extracranial part. First is intratemporal. So in intratemporal, if we take, this is first is meatal or canalicular segment, which is 8 to 10 millimeter. It starts from porus, which is the medial end of interauditory meatus, to fundus, which is the lateral end of interauditory meatus. There are no branches. Now again, I will tell, this is the very important relation at the porus, where it is entering the this interauditory meatus. It lies anterior inferior to the eighth nerve, but as it traverses through the interauditory meatus, it becomes anterior superior to the eighth nerve, and nervus intermedius lies in between. So, and midway in the interauditory meatus, the eighth nerve divides into cochlear and vestibular nerve, and closer to the lateral margin, it further divides into superior vestibular and the inferior vestibular nerve. So this is very important, because when we are doing surgery for acoustic neuroma and we are lifting the superior vestibular nerve, we must be careful that in the lateral part, facial nerve is anterior superior, whereas in the medial part, it lies anterior inferior. Further, if we go into the cross section at the fundus, when the nerves are about to come out of the interauditory meatus, that again is a very important relationship. Now this is interauditory meatus at the fundus is divided by falciform crista falciformis into upper and lower, superior and inferior part. Then another superior part is further divided by Bill's bar into anterior and posterior parts. Anterior part is filled by facial nerve and nervus intermedius. The posterior part contains superior vestibular nerve, and it is formed by the utriculoampullary nerve, which is the confluence of utricle, superior and lateral ampullary nerve. So posterior ampullary nerve is not included in this. It contains utricle, superior and lateral ampullary nerve. Whereas the inferior compartment contains cochlear area anteriorly, which contains cochlear nerve, and inferior vestibular area posteriorly, which contains the saccular nerve and singular foramen posterior inferiorly, which transmits the posterior ampullary nerve. So this singular foramen is the one which carries the posterior ampullary nerve. This is to be understood very nicely. Now I am showing a picture of a left interauditory meatus. This is the dura, superior, inferior, anterior, posterior. Now you can see this is the horizontal bar which is separating the facial nerve and superior vestibular nerve from the cochlear and inferior vestibular nerve. And this is the Bill's bar which is separating facial nerve from the superior vestibular nerve. And once we are doing some tumor surgery, acoustic neuroma, we are lifting the superior vestibular nerve, taking it down. Then the facial nerve, which is anterior superior in the lateral part, gets anterior inferior in the medial part. That relationship is to be remembered always. Now coming to the surgical relevance of this part. Facial of orientation and relationship with the surrounding structures of CP, angle, and internotory meatus, which is very, very important to know. The changing relation between facial nerve and vestibulocochlear bundle and CPA and internotory meatus needs to be understood to avoid traumatizing while removing the tumor. Another important point to remember is that the facial hair is covered only by a thin layer of glia, so it is very much vulnerable to trauma due to surgical procedures, though it is quite resistant to compression and stretching during the growth of a slow growing skull base tumor. Now, because that's why the facial nerve palsy presents very late in the skull base tumor, because it can resist a lot the compression and stretching caused by the slow growth. So that is very important to remember. Next important point is the extension of meningeal layers up to the geniculate ganglion may cause spread of viral inflammatory process from one segment to another segment of the facial nerve. Because the layers may be going up to geniculate ganglion, so the inflammatory process reaches there. This is a case where I'm showing this is superior vestibular nerve involved in the acoustic neuroma. We are lifting and pulling it down. This is the left side, this tumor with superior vestibular. This is facial nerve. Now inferiorly the nerve goes like this, so we have to be really careful for identifying the nerve. Now in situations of tumor, surgery, iatrogenic or post-traumatic injury to facial nerve and internal auditory meatus, once the nerve gets injured here, there can be complete absence of the stump, unavailability or unavailability of the proximal facial stump. In case of available stump, there is chances that we can use a free great auricular nerve or sural nerve interposition grafting. Now this you can see in this diagram. This is the interauditory meatus. This is the intact nerve. When there is injury and some part of the nerve is missing, in the intracranial part only. So we will do the grafting intracranial to intracranial. But if a bigger part is gone, then we will take a bigger sural nerve graft and put it intracranial to extra temporal. This bigger graft can also be taken, but we should be having a proximal stump there. So we really have to be careful to be saving this proximal stump. And in case, now this was a case of facial nerve neuroma. Here the proximal stump is present, though it is very small in the end of the labyrinthine segment. This is the facial nerve stump at the stylomastoid foramen. The whole nerve was involved, has been taken away, and this is a big graft placed there. We can use a glue to put there because the suture will not reach. This is such a narrow and deep area. Here we will put the sutures. There you can see I put a glue and we got a really good results here. This is the left side of the patient. Whereas in case this is the right side of the patient, again this was a case of a revision case where gamma knife was given for a facial nerve tumor, and after gamma knife and incomplete this control of the tumor, it led to the necrosis of whole of the facial nerve, and this tumor was still occupying the labyrinthine segment and the interauditory meatus. So translabyrinthine approach was then done. Labyrinthectomy has already been done. Now this is the stylomastoid foramen. This is the right side, and this is the tumor in the interauditory meatus. Now we cannot be leaving the tumor behind. In this case, you see, I can find a normal nerve there at the stylomastoid foramen. We go 1 or 2 millimeters more lateral to include the hidden microscopic extent of the tumor. Cut it here. I have cut it here. Now this is being taken out. Medially, the tumor was involving up to the medial end of the interauditory meatus, so I had to cut it there. Now there is no stump to put a suture, to put a free graft there. So we closed it with the fat and glue because it has to disconnect the intracranial part. And then either in this case I did fasciomesenteric anastomosis, which we will take up one by one. This is the most boring, I mean, to make people understand the anatomy, though the further lectures will become very lively and interesting. I'm trying to make it so. So this is the right side, the masseter nerve. I will show you in one of the lectures, fasciomasseteric anastomosis, and one will be on fascio-hypoglossal anastomosis. So this nerve was separated. This is the stump of the facial nerve. I put a great auricular nerve between the two because the stump was small. Either fasciomasseteric anastomosis or the fascio-hypoglossal, end-to-end or end-to-side. So this is a situation when there is no proximal stump available there. If proximal stump is there, we can take as long a graft as possible and can do the repair there and then only. Now coming to the labyrinthine segment. Labyrinthine segment is the most important segment to be well read by a otologist because this is the narrowest and the shortest segment. Narrow means 0.5 to 0.7 millimeter and shortest means only 3 to 4 millimeter. It starts from the fundus of interauditory meatus and reaches the geniculate ganglion. You can see it here, diagrammatic depiction. Now, it is one thing very important is it's devoid of epineurium. So lesser safe. It doesn't have an outer hard sheath. Then this is the narrowest part of this fallopian canal here at the exit. This becomes 0.68 millimeter square, that narrow apart. Then there are two sharp bends the labyrinthine segment faces. One at the start, it makes one angle of 132 degree with the interauditory meatus, and second is very sharp 90-degree angle with the geniculate ganglion. So this has got two bands, but this one is more narrow. So this is a stuck part of the facial nerve and can get easily inflamed, and edema doesn't go and causes the ischemia. And another important point is the facial canal is so narrow that it occupies 83% of the canal, whereas rest of the segments are occupying lesser space. Then another important point is it has got single arterial supply with a very thin diameter, which is superficial petrosal artery, whereas rest of the intratemporal part of the facial nerve gets dual arterial supply. Now coming to this, you can see this is the left side of the surgical position. This is the labyrinthine segment. If we see this small, the whole nerve, sharp bent there, stuck between this bony canal. You can see it here. So this big an angle. So it is quite difficult to reach here, and if once it get injured, then it is really difficult to relieve the edema. If we see this superior view of the labyrinthine segment, this again is the left side. If we take from the superior side, this is interauditory meatus. This labyrinthine segment is hidden here, reaching the geniculate ganglion. So it lies, relation is anteriorly is the basal turn of the cochlea, posteriorly is the superior semicircular canal, inferior to it lies the vestibule, and superior is the tegmen. So this is the superior view because I want to make the labyrinthine segment well understood. So what is the clinical relevance of this labyrinthine segment? A bottleneck is created as it exits from the interauditory meatus, making it more vulnerable to compression. What are the four things which make it narrow bottleneck? That is narrowest in width at its exit, cross-sectional area is already told. There is a arachnoid band present around it. Fibrotic arachnoid band is also present. Then sudden reduction in diameter of bony canal, and then sudden bend. So four things make it a very narrow and difficult to reach area. Due to the narrow diameter of labyrinthine canal, the facial nerve occupies up to 83% of the canal's cross-sectional area compared to 73% occupancy in the appendix segment and 64% occupancy in the mastoid segment. Very important. Second is arterial supply to the labyrinthine segment is single and without any anastomosing arterial arcade. I will show in the blood supply slide how what I am trying to tell. Unlike the rest of the segments which have got double blood supply, now the important thing is the internal diameter of the main artery supplying this segment is also very less than other segments. So narrow canal, less space around, the supplying arteries are also so thin and small. So it becomes like difficult to relieve once the edema or inflammation happens there. So as space for the facial nerve and artery supplying it is very less in labyrinthine segment, any inflammation leading to edema of facial nerve can easily lead to ischemia of the nerve, making it more vulnerable for facial palsy than any other segment. And as we keep telling Bell's palsy, because that is a complete inflammatory process, it usually happens, and the residual is there in the labyrinthine segment also. So surgical relevances in Bell's palsy, labyrinthine segment most commonly affected due to anatomical constraint leading to residual edema and ischemia. If decompression is needed, labyrinthine segment to be definitely decompressed. Another thing is when I'm going to give lecture on the post-traumatic facial palsy, the transverse fracture line almost always passes through labyrinthine segment and geniculate ganglion. So people in West have chosen middle cranial fossa approach to decompress that, because through mastoid approach we cannot reach these areas. So these areas are always to be decompressed, and we have devised especially the transzygomatic anterior attic approach, which I'm going to show you in one of the lectures. How to reach this area simply and straight in one go, I will show you. So this is the area for the post-traumatic facial palsy gets affected. As there is no epidural sheath, we need to try to open, sheath is not there, so we should not try to open the sheath beyond geniculate ganglion. And edematous entrapment of the facial of the meatal foramen, the narrow segment, may lead to nerve ischemia or necrosis and subsequent facial. Now, we do surgery on acoustic neuroma. At that time, immediately post-operative, the facial nerve is okay. But this edema, when it goes in the proximal part and affects the meatal part, there can be delayed facial palsy. So this is how it looks. Meatal foramen narrow. This narrowing can cause this is called damming of neuroplasm. This leads to edema of the meatal segment. This is the labyrinthine segment. So unless until we remove this bone over there, this whole thing is not going to settle down. Now coming to geniculate ganglion. Geniculate ganglion is a sensory ganglion. It is located in the, now you, again from the superior view I am showing, this comes from the anterior 1/3 of the first genu area. This is the first genu area. And GSPN arises from its anterior part. The relations are, now the cochlea, which was anterior to the labyrinthine segment, becomes medial to the cochlea. That this medial to the cochlea becomes medial to the geniculate ganglion. Lateral to geniculate ganglion lies the middle ear. Superiorly is the middle cranial fossa dural place. Anterior medial is the internal carotid artery. And posterior lateral is the lateral semicircular canal. So this is how it looks. This is the close-up view. So why is it important? Because it contains all the sensory, motor, special sensory and parasympathetic nerve fibers going through it. All the fibers pass through it, but only the sensory nerve cell bodies, first order neuron, are located in geniculate ganglion. The rest of them are just passing through it. So surgical relevance is, again, it is along with the labyrinthine segment commonest site for injury in post-traumatic facial palsy. And when I read, went through the literature, the dehiscence in the facial nerve is very common. We feel that that is very less, though 30% of the cases we find the facial nerve dehiscence in intratemporal region. And out of those 30%, around they say 70% is in the tympanic segment close to oval window, but 16% are in the geniculate ganglion and just above the processus cochleaformis. So that's why again there can be edema leading to the compression of the facial. Coming to tympanic segment, I hope it is not a very boring lecture, though the anatomy is always like that, Dr. Ahmad. I hope I'm not making it very, I'm trying to make it slightly interesting. Tympanic
Okay.
segment is 8 to 11 millimeter. At G1, it takes a sharp turn posteriorly 90-degree, posterior lateral direction along medial wall up to G2. So relations, as we all know as otologist, inferiorly lies from anterior to posterior transtympanic as a tympanic tensor tympani muscle, cochleaformis process, oval window, pyramidal eminence. All four lie inferior to it, and superiorly is the cog. It is a bony structure which connects the segment to the this neck of the malleus. Posterolateral is the lateral semicircular canal. We all know tympanic segment so well. So this is the tympanic segment. All disease taken out. This is whole of the this vestibule and the semicircular canals. So this facial nerve, I just want to say this is slightly out of the context. When we do canal wall down mastoidectomy, just see the canal wall reaches up to this. So 4 to 5 millimeter of canal wall can be easily, canalplasty can be done till we reach the anterior margin of the tympanic segment and the vertical part of the fallopian canal. So we should not worry. This is called thinning of facial ridge and lowering of facial ridge. Now see how deep is the facial nerve. This is the lateral edge of the mastoid cortex. This is so deep, and surgeons start getting terrified very early because they have not actually seen the, through the temporal bone dissection, they have not actually seen the tympanic segment. Now again, this is the previous one was with the labyrinth intact, and this is after labyrinth. We can easily see how it takes a turn there, then becomes a mastoid segment. Surgical relevance is, as I told you, dehiscent facial canal, most common is the tympanic segment, 83%, or more exposed to iatrogenic trauma. Again, if it is, I have seen in few cases when there is a pseudomonas infection, very bad cases of ear surgery, we start the antibiotics many days before the surgery on based on this culture sensitivity, and post surgery also the follow-up with accurate antibiotics is to be done, because if there is a dehiscence in micro dehiscence in the tympanic segment, any infection and inflammation can cause delayed facial palsy, and unnecessarily the patient can blame you that you have not done, and you also get terrified. Okay, then you got doubtful whether I did something wrong to the patient or not. So we must always have an eye for looking for dehiscent facial nerve and try to avoid infection in post-surgery cases. Also, the relationship of facial nerve to the oval window, circular, semicircular canals, annulus puts the nerve at risk while performing steps for canal wall down or up, mastodectomy, ossiculoplasty, or whatever. So this is the most, we come across this area the most often. So we must know how to handle it. From G2 to mastoid segment is 8 to 15 millimeters, two branches. The nerve turns inferiorly at an angle of 95 to 125 degree with the G2, a few millimeter posterior to the posterior edge of the pyramid. It first lies anterior medial to the lateral semicircular canal. When it goes inferiorly, it becomes anterior lateral to the posterior semicircular canal and lateral to the annulus. And G2 to stylomastoid foramen and bony fallopian canal. Now you can see this. The important thing here is just see tympanic segment. This much widening can be done in the canal, one thing, and this much lowering can be achieved very easily, because I will show you the what are the important measurements. This is so medial, and this is the lateral semicircular canal. Thus, after second genu, the upper part of the mastoid segment lies anterior medial to the lateral semicircular canal, whereas the lower part lies anterior lateral to the posterior semicircular. Suddenly it takes a turn laterally, and as it is bending there, there is a bump there. That is to be taken care of when we are doing surgery. This is the area which gets mostly get iatrogenic injury here. And the medially lies the annulus. Mastoid segment lies lateral to the surface of jugular bulb, bisecting it anteromedial to the digastric ridge. This is the picture for that. You can see this is the jugular bulb, and the mastoid segment bisects the jugular bulb, and digastric ridge is pointing towards it at the stylomastoid foramen. It has two branches, nerve to stapedial, most proximal branch given at the level of pyramidal process supplies the stapedial muscle for a stapedial reflex. Chorda tympani has got two kind of fibers, GVE and SVA. It arises 4 to 8 millimeter above the stylomastoid foramen. It lies lateral to the long process of incus, medial to neck of malleus, then through petrotympanic fissure to infratemporal fossa. There it joins the lingual nerve and reaches the submandibular ganglion, and there it supplies the this fibers SVA, and then it takes the special vessel efferent from the anterior two-third of the tongue. So important measurements to be kept in mind. The tympanic segment to cochleaformis process is 2 millimeter. It lies superior medially 2 millimeter superior medial to the cochleaformis process. Then geniculate ganglion to cochleaformis process is again 1.5 to 3.2 millimeters. This tympanic, and then G2 to LSCC. This is the second genu. It is 2 millimeter. Mastoid segment to oval window, 4 millimeters. Mastoid segment to round window, 4 millimeters. Now, most important is G2 to outer cortex is 21.6 millimeter, whereas stylomastoid foramen to outer cortex is 12.8 millimeter. So these two show that when we are superior part, then it is very deep, 21.6 millimeter to the outer cortex, and when we reach the stylomastoid foramen, it is only 12.8 millimeter deep to the outer cortex, though it is still deep. So we can reduce that 1.28 centimeters without any worry. So extracranial at stylomastoid foramen, less than 4-year-old, it lies superficial, prone to injury because the mastoid tip has not developed. In adult, the nerve is protected by mastoid tip, this tympanic plate, ascending ramus of mandible, and fascia between the cartilaginous external canal and the parotid. So it is quite safe there in the adults. After exit, it runs parallel and superior to the superior margin of the posterior belly of digastric, gives 2 to 3 branches in the neck, which is posterior auricular nerve, supplies the intrinsic muscles of the ear and occipital belly of the occipitofrontalis muscle. Second branch is the motor nerve to the styloid muscle and the posterior belly of digastric. These 3 branches are given before it reaches the pes and serenus and gives the rest of the branches. Then if we want to localize a facial of trunk at the exit of stylomastoid foramen, we all know these are 4 very important pointers. One is tragal pointer, points anterior inferiorly, and the facial of stylomastoid foramen lies 1 to 1.5 centimeter inferior and deep to that. Tympanomastoid suture line, very important. It can be palpated with the hand. It is a hard ridge deep to the cartilaginous extraocular canal. The facial of this is very important. Facial nerve emerges 3.5 millimeter deep to its outer edge. Then posterior belly of digastric muscle facial nerve lies 8 millimeter above and parallel to the upper border of the PBD near its insertion. We have to be sure, closer to the insertion. And when I have seen in my cases, when I've opened it up, it's really in few cases takes some time to really locate it. I have seen this nerve to be slightly closer towards tragal cartilage than the digastric muscle. At pes and serenus, we all know it turns anterolaterally into the retromandibular fossa, crosses the lateral surface of styloid process, and then parotid gland and divides into all the 5 branches: temporal, zygomatic, buccal, marginal, cervical. How it divides? We will talk about this. These are the 5 branches, terminal branches, and they supply all the mimetic muscles of the face, which I will not go into details because we can read it. Now, temporal is the frontal branch. Temporal is also called the frontal branch. You can see this leaves the parotid gland at it. It is very important to know because many times you have to do the retrograde identification of facial nerve in many cases, and then we must know how it leaves the parotid gland at its upper pole just anterior to the superficial temporal artery, crosses lateral to the periosteum, the zygomatic process. Just see, it is lateral and very prone to injury. If I am looking for a masseter nerve, this branch can easily get injured because we are operating here below the zygomatic arch only, and traverses the temporal region lying underneath the temporoparietal branch. Then zygomatic branch, it emerges from the parotid at its anterior superior border, and after crossing the zygomatic arch, it reaches the face. Buccal is nerve for smile, may arise from both temporofacial and cervicofacial branches of facial nerve. This is called the nerve for smile because most of the, angle of mouth zygomatic muscles are supplied by it. And when we find the masseter nerve, fasciomasseteric I have been doing quite frequently, but many times I have seen because facial nerve has got 10,000 fibers. The masseter has got 7,000. Mostly it is thinner than the thickness of the facial nerve. So many times to gain the strength, what we do is we do it end-to-end anastomosis with buccal branch only, along with this upper eyelid implant for the eye closure. So that gives better results many times if the masseter nerve is thinner than the facial nerve, and we will do a buccal. So marginal mandibular. It emerges from the parotid gland at its lower pole, runs below the angle of mandible under the platysma but superficial to the deep cervical fascia, passes through the upper part of digastric triangle, turns up and forward across the body of the mandible. And cervical is emerges from the posterior inferior surface of the gland and innervates the platysma. Now, this is the three important point. This was a cadaver study of surgical landmarks for retrograde parotidectomy. Okay. So one point is there are 3 pointers. I can choose the bigger picture. This is one pointer. This is another, and this is the third pointer. So let me first read it. Okay. The first pointer is the point at the distal end of the zygomatic arch just before it becomes the frontal process of the zygoma to the more superficial buccal branch just up before its emergence from the parotid gland. So this is the body of zygoma. This can be easily palpated, and where it becomes the frontal process of zygoma, there we should be looking for this zygomatic branch. Then for buccal branch, the most superior point of the retromandibular vein, this is the retromandibular vein. Just after its emergence below the parotid gland to the marginal mandibular branch of the facial nerve, just before its emergence from this is for the marginal mandibular branch. And the third is point at the angle of mandible just before it becomes the rambus. This is that area. To the marginal mandibular branch of the facial nerve just before, after its emergence from the facial nerve, parotid gland. So this is the zygomatic. This is for the marginal mandibular branch. Many times I've seen, I don't know how many you came across, I have come across many cases of extratemporal facial nerve injury. Mostly it is the post-traumatic iatrogenic or the roadside accident. Here it becomes, if it is completely cut, it really becomes difficult to identify the proximal and the distal end, because here even the nerve monitor does not work because both ends are cut. You cannot know where, because the transmission of nerve is not there. So by opening it up through the fibrosis and the possibility of digastric, this is the left side of the patient. A child was operated from brachial sinus, and the previous surgeon caused injury here. So when I started looking for it, I could first identify, it took a lot of time, identify the proximal end, then the distal end could be located, then the fibrotic part was cut, and both were end-to-end anastomosis was done, and getting really great results. Grade 2 facial recovery was there. And this is the right side of the patient. Patient was operated for parotid surgery. He came with parotid fistula. So you may not be able to see, this is the facial nerve at pes and serinus. These are the two branches. These are the two branches, marginal, mandibular and cervical. These are the buccal or zygomatic, whatever, these were the branches. So I could identify them by gentle. When you get obsessed with facial nerve, I tell you, you will find it where it is. It gives such a white glistening look there. You cannot miss it. So once I identified all the cut branches, so I took a great auricular nerve with its further branches and put it there very gently with few very fine 80 or 90 monofilament. I put sutures to the main trunk and both the branches, and I could get result up to grade 3, and the eye closure could be achieved with the this upper eyelid implant. So don't leave any case in unattended, because I have seen miracles happening. And once we know the anatomy, we will know how to look for it in the face and put the nerve graft there. And then this few last slides, there is a new classification of branching pattern of facial nerve during parotidectomy, a cross-sectional study that was done. And this study was done with Omar Salim Khattab Alama, and he divided it into 3 segments. The division of the facial nerve in the this stylomastoid foramen. One was type 1, 2, 3. Second was ABC, and third was 1, 2. So what was type 1? Single facial nerve trunk dividing into 2 main division, into temporofacial and cervicofacial, then into branches. That is what we read all around all our early times, that this is how the facial nerve divides. Then there is a second variety also, that single facial nerve trunk that divides directly into final branches without the 2 main divisions. So immediately, without getting it divided into 2 main divisions, it divides into 5. Third is, there are separate double trunks of facial nerve, each giving final branches. So these are the 3 types. And second division is depending on the length of the stump available, which is 1 to 10 is A, 11 to 20 mm is B, and 21 to 30 mm is C. And 1 or 2 is when there is no communication between the branches, and so second is communication between the branches. So whenever we are doing parotid surgery, if we know these varieties are there, we can find it. We will not look it like in a traditional way. We will have everything in our mind, and these are the diagrams they drew to show how these are different varieties present. So they came out that 1A1 was 34.78. The commonest was dividing into 2 and further branches, and rest all varieties are there. We can always go through the literature to read them, because these anatomical fine points can make us a better surgeon, because we shall be taking care of extra temporal part of the segment also. Coming to blood supply of facial nerve, very interesting blood supply is there. There are 4 vessels supplying the whole of the facial nerve. When it is in CP angle, then ICA, anterior inferior cerebral artery from the basilar artery, supplies the CP angle. Then the labyrinthine artery from ICA only supplies the internal artery meatus, though it is named labyrinthine artery, but it supplies the internal artery meatus. Whereas the labyrinthine segment is not supplied by that, it is supplied by the superficial petrosal artery of the middle meningeal artery, which is a branch of the maxillary artery. So this is the area that is supplied there. And rest of it, it goes up to the geniculate ganglion and the half part of the tympanic segment. Then the fourth is stylomastoid artery, branch of the post-auricular artery from the external carotid. It supplies the mastoid segment and tympanic segment. Now you can see the spirals in the presentation of the artery. There is arterial arcade formation. So from here till here, it has got double blood supply. Both are overlapping, so it makes it stout and stronger nerve, whereas this labyrinthine segment has got only one supply. And there is this plexus lies in the external epineurium, external plexus, and then it feeds the intraneural internal plexus. So even the epineurium is important, because the space between the epineurium and perineurium lies the most of the vessels. So each intratemporal segment dual supply, I've told you, no anastomosis. And that's why when we are doing anterior transposition of facial nerve and posterior transposition of facial nerve, unknowingly, or we don't have any option, we take away the blood supply. And many times people have seen even a very good anterior or posterior transposition leads to grade 2 facial palsy, because of the compromise on the facial arterial supply. This is the last spatial orientation. I was very much interested how the nerve fibers are arranged and whole of the length of the facial nerve. This was again a study done by Mark May. It was done on dogs and cats. These creatures were taken. They found that the spatial orientation was there in the central part of this thing from the upper motor neuron. But as we came down, they did some kind of study, and that they found that the forehead and eye was lateroanterior, the lower lip was anterior medial. Very nicely they have come up. You can go through it all. But honestly, one or two cases, I had a very interesting case. This is the last slide, please. This patient I was operating in Mumbai for a iatrogenic facial palsy, happened 1 month back by a surgeon. This is the left side of the facial nerve. Interestingly, the House-Breckman classification cannot be applied on this, because her eye could close, but rest of this thing, it was already 1 month. You see the video. Eye is closing nicely, but rest of the forehead absent, lip function absent. Just see how bad. So then I thought there must be something there. Then I operated. He said I had not gone close to the facial. Just see, if the surgeon says if with this facial palsy that he has not gone close to the facial nerve, then that means he has definitely done some injury. Now see this video of this patient. Very interesting. I could see this the left side semicircular canal. This the vertical part of facial nerve. You can see this completely cut. Again, I will show you. This is a traumatized facial nerve. The whole tympanic segment is gone. Now I am taking away the lacerated part, upper and lower part. Now you see, can you see there is a intact facial nerve there? Just see. Sorry. So this facial nerve fibers, never cut these fibers because they can be supplying the important part of the face. So you can see this is not anterior medial, this is not the posterior lateral what the Markme was saying. These intact fibers are anterior medial and they're supplying the eye part. So there is some kind of spatial orientation is there. I feel we shall be doing more researches on this so that we are able to find this house Breckman classification does not suffice. We have to form like eye face or something because iatrogenic injury does not give uniform facial palsy. There can be intermittent palsy of some part and rest of the face might be working nicely. So here because the great auricular nerve was very thin, so I did a double loop graft was placed. You see, I doubled up the graft. Now, because at the bent area, there is no way how the fibers are going through it. So I'm giving a cut at the bent of the loop so that now the nerve fibers can grow through this dual nerve graft. So it gave really good results. I am in touch with that patient is already 2 years now. So this is just to show that spatial orientation does exist. Maybe we don't know because we cannot do this research. We need to do it on animals only. So this is the proper placement of the graft has to be there. Even glue or suture both give equally good result. That approximation should be there and we have to cover that anastomotic site with the pieces of perichondrium so as to keep the cut ends in place. And I will put a glue. Never put a glue while when we are approximating this. We put it after we have approximated the ends to each other. So this is how it was operated and I will show you just the So now happy face is there. Most of it has recovered, though grade 2 is still slight recovery still needs to be done, but she is more than happy with that. So thank you very much for such a elaborate, lengthy, for paying attention to such a elaborate and lengthy lecture. Thank you very much.
Okay, thank you, Dr. Mehta, for comprehensive and interesting lecture. Maybe we continue with the discussion. We have some question in the chat.
Okay.
One from the Dr. Eva. She want us about the if facial nerve totally damaged, how to graft it.
If the facial nerve is, can I read the chat box?
Yeah, you can open the chat.
Okay, then the first is
The first is from Ifa. She asked about the if facial nerve totally damaged, how to graft it.
How to graft it? So now, as I've shown the anatomy, now we have a zoomed out view of how the facial nerve goes. Depends on where it is located. If it is intracranial, we have shown you that we can put a completely cut facial nerve, can either end-to-end anastomosis, that is the best if it is possible. Usually, if it is iatrogenic, the cut ends are get lacerated. So many a times you have to cut the lacerated end and put a small graft. As I've shown you, if it is partial cut, we give partial grafting, complete cut, complete grafting. But end-to-end anastomosis always gives better result because it brings it to grade 1 normally. When we are putting a graft, chances of slight less improvement is there because the nerve fibers have to grow through it. But if I've seen over the years, if a nicely done graft is there, then we give maximum results there. So we can easily, and if it is totally damaged, we don't have any proximal stump with us, like in cases of skull-base osteomyelitis, any tumors or bad trauma or iatrogenic, then we have to choose a separate, proximal stump motor supply, which is either from masseter nerve, which is a branch of trigeminal mandibular nerve, and the other is hypoglossal. Now slowly the trend is shifting toward the masseter nerve because it is not supplying very important muscle. There are other supplies also. So masseter doesn't give any residual function defect, whereas hypoglossal, though end-to-end with hypoglossal gives very good result, but the half tongue gets slightly atrophied and loss of function is there. So now partial thickness, we are doing end-to side anastomosis and putting a graft in between the stylomastoid foramen, the facial stump at stylomastoid foramen with the hypoglossal end-to side. When we put a graft in between, again, the results will not be very good, grade 2 or grade 3. Then what we do, rather than cutting at stylomastoid foramen, we go and cut it and do a mastoidectomy, some bit of more, bring the nerve from second genu down. So the whole length, extra length of 32 millimeters is got, and that is the length which is required between the, because if we are not cutting the hypoglossal completely, then we are not able to cover the distance. So rather than a stylomastoid foramen, if we cut the nerve at second genu and revert it down, then very good result with the fascio-hypoglossal also. So I hope you got the result.
Okay. So maybe I add some question. How long we should wait for evaluate the function after the graph?
Okay. When we do end-to-end anastomosis, then the recovery is first is decompression. Decompression, if nicely done within 2-3 months, the results showing very well, and less than 6 months, the facial nerve becomes normal. Now coming to end-to-end anastomosis. End-to-end anastomosis, because the nerve to nerve 1 millimeter per day, they say, but it is slower than that, and it takes around 1 year, 9 months to 1 year minimum, to show that patient starts feeling okay. Now I'm getting. This is very important, that the diameter to diameter is very important.
Okay.
Very important to do that approximation. And if we have put a graft, then even 2 to 5 years. One, that extra temporal I showed you, that he was operated somewhere with parotid fistula. I just did it because I thought it will never work. That nerve was so badly mutilated. But the recovery of facial nerve gives me so much encouragement and confidence that next time also I'll be doing it. I took all the time. I took it like a gone case and did very beautiful repair. And then patient got did a upper eyelid implant also. Always consider that whenever you are slightly doubtful, not because your surgical technique is not right, but because that the trauma is so bad. So eye at least remains closed during those 2-3 years. Immediately, I counsel my patient to get the great auricular, this upper eyelid implant in the same or the within 10-15 days, so that eye is closed. Patient is happy, his eye is closing, because eye and angle of mouth, these two things disturb him. So when eye is closing, you can wait for 2-3 years slowly over the time. And then that patient came after 2.5 years. I could have shown, because this is an anatomy lecture, I would show when I go ahead that patient improved. I was surprised beyond my this thing, that such a bad case. It never seemed that I have done attached to this anastomosis to the right nerve branches, but really, that was really heartening and encouraging. So never give up on facial nerve.
Okay, thank you. Maybe we continue to the next question. You also
I
can
can
see in the
read.
chat.
In cases of peripheral facial nerve palsy due to cholesteatoma complications, when performing facial nerve decompression during mastoidectomy, is it sufficient to perform bony canal decompression alone, or is it necessary to open the nerve sheath as well? I will answer till this, then we will read further. Okay. If it is a cholesteatoma surgery, and that was the two ways the nerve can be affected. One is due to disease only. Second is we have done some iatrogenic injury. If it was due to disease only and the patient presented with cholesteatoma with facial paresis, it never is palsy in cholesteatoma, because this is tough. The epineurium is tough. The bone gets eroded, but the facial nerve remains that. Just edema and compression causes the facial paresis. So in that, just taking away the bony canal, few millimeters proximal and distal to the area of dehiscence, clearing that area of granulation with, cotton balls soaked in steroid or this adrenaline. clean it nicely, go 3-4 millimeters on both the sides, separate the nerve from around, but never, ever open the nerve sheath. Epithelium is not to be cut because it is a sacred sheath. If we open it up, we may cause infection to traverse into the facial nerve. Then it will take a very long time. But if it is already, we have traumatized it there, then if the nerve sheath is already opened, then we have to repair as it is. So we don't cut in infected cases, don't open the sheath. Just bony decompression will suffice. And second part of the question is, what is the risk of infection spread if the sheath is open in cholesteatoma cases? Believe me, it really gives a longer time of facial nerve palsy. A patient takes longer time to recover, and we really have to be good with antibiotics because ear cases are really, how I have improved on the chronic resistant cases is when the patient comes, I get 2-3 times culture sensitivity done, give the accurate antibiotics, get it written from the patient on the paper that this ear is going to take at least 1 year to dry up even after surgery because the bacteria are really bad. And if there is a facial of paresis or palsy, that this infection is going to ruin that facial nerve, and the patient may take very long to recover from the facial nerve paresis. Now coming to
the next question
in
from
nerve
the same person.
Okay. The same question. In nerve grafting procedures, are there any tips for harvesting and cutting the donor nerve, for example, the sur nerve, such as the type of blade used and the proper cutting technique to obtain an optimal graft? This is very important because we have to have a very clean cut and elliptical cut. Elliptical cut to have maximum fibers for the facial nerve fibers to grow through that. Because the donor free graft is now acting as a tubule. It does not become part of the facial nerve. The facial nerve fibers grow through these tubules and they have to be approximated in that way that it gives maximum chance to the maximum nerve fibers to grow through them. That has to be elliptical. And you know that cutting blade we get surgical blade, the much better blade is, there's shaving blade. Fresh shaving blade, it really gives a very nice cut. So you can try that. And once it is done, then we have to remove every bit of superficial soft tissue around the nerve, and that will do. Okay.
Okay.
And slightly 10% bigger than the size of defect there in the nerve because it should be lazy C or S in a way. Because slight traction on that can lead the approximation and osmosis to get separated, and the patient has got only one chance. We will not know. Honestly, we will not know that the anastomosis is working or not. I have a driver who had suffered an injury for this arm. He got a fracture there, ulna and radial bone, radius bone. He went to our orthopedics. He did the repair and put the plaster for 3 months. And after 3 months, that bone is projecting. There is malunion. So bad because the patient put all the faith on us. And in the same way, facial nerve, he thinks that we have done a good job. And we must make sure that the anastomosis is good, approximated. If we are using glue, don't use between the cut ends, put it over the anastomosis and put a wrap in 270 of this perichondrium for anastomosis to stay there.
Okay.
Is suturing mandatory? No, okay. Such that is suturing mandatory, or can the graft be secured by simply wrapping it fascia, similar to being covered like a banana leaf between the Yes, absolutely. I went through literature while I was writing the book, and my cases also beautifully heal up when we use the glue, but it has to be nicely approximated. The suture gives one step extra confidence that we have sutured, that it is not going to move. But if we have done a good anastomosis, believe me, they give equally good results. We should be doing a good approximation. Coming to next.
Next.
What is the maximum time to do nerve decompression for Bell's palsy? Bell's palsy usually 80-90% cases improve on their own. I take it like 1 month has passed, and the nerve, this grading has not improved. If it was grade 5, it has not come to 4 even.
Mm.
It has not budged even.
Mm.
1 month, 1.5 months. I mean, maximum 6 weeks I wait. Then I get a CT MRI done. There
Yes.
could be some dehiscence. The viral has got inflammation there, and that dehiscence itself has caused this inflammation, edema, and then causing compression. So then I can take up that case. So if there is a dehiscence, I will open it up. I will open it the labyrinthine segment also. I've seen recovery happening, because believe me, if it is your face, if it is my face, and one and
Yeah.
a half month has passed, I have not been able to achieve grade 1,
Yeah.
then that is bad.
Mm.
That is really bad. So we cannot say that Bell's palsy does not need. We are not after surgery. But once the patient is not improving, it is not budging from grade 5 to grade 4, same similar, then there has to be either some other reason, or inflammation has got trapped somewhere. Either it is labyrinthine segment or some dehiscent segment. We will look nicely into the CT MRI and then go ahead and do the surgery.
So the CT-MRI we should perform
Yes,
after the 6 weeks.
yes,
See,
absolutely.
because for the
Yes,
evaluation.
not
Okay.
before that, not before that.
Okay.
And second, we do it when Bell's palsy has happened for more than once. Then
Mm.
that means it may not be viral, it can be facial neuroma, which gives intermittent facial palsy and recovery, because all fibers are not involved. Neuroma causes a compression of fibers. It is not a tumor of the schwannoma, facial schwannoma. It is not a tumor of nerve, it is the tumor of the Schwann cells, the sheath.
Mm.
So that way, in that case also, to rule out the facial of schwannoma, we get a CT MRI. Otherwise, they improve on. But important thing, as I said in the starting, Mona Lisa smile, that was just a joke. But yes, when it is recovering, please call the patient regularly, because
Mm.
the synkinesis or hyperkinesis occurs when the recovery is taking place. After 2 to 3 weeks, we have to be in constant touch. We keep telling them mime therapy, physiotherapy, so that they should be knowing that I have to be careful about the angle of mouth, ocular synkinesis, oculo-oral synkinesis, mass hyperkinesis syndrome. All these are to be avoided, because complete recovery has to be there. Treat this patient as it is happening to you, facial palsy. So most Bell's palsy are not that notorious, but still few can leave scars. And what
Okay.
is the maximum time to nerve grafting on
Yeah.
traumatic patient of due to tumor or cholesteatoma, and when to choose reanimation? Okay. In cholesteatoma cases, believe me, we have got results even after 7 years. Don't give up on the primary repair. If it is cholesteatoma or post-traumatic, maybe the graft has got displaced the previous surgery. Maybe the disease had caused it. We tell the patient that if it is more than 3 years, I get a electromyography done. If it says total dead, still I will tell the patient that I'm going to do a gold implant surgery along with the primary repair. What is the harm? Primary repair with gold eye implant, the sling and all can wait for some time. We keep them physiotherapy, and primary repair is done in those cases, and we can wait for some time, at least some bit of improvement on the face. Gives the confidence that it has become alive. Otherwise, this dead feeling is really bad. Because reanimation procedures are just to compensate for this.
Understand.
Phase.
Okay. The next question.
What is the tips and trick to reduce the facial injury during the surgery when the nerve is still normal? And tips on how to identify injury from the pathologies during the surgeries. Slightly, I couldn't get it. Still, I'll try to answer. What is the tips and trick of reducing the facial injury
Maybe
during
the
the
landmark for the fascia nerve when we
Okay.
perform the surgery.
Yes, perform. That is, believe me, I'm not just saying it for the sake of saying. Uh, we do as much temporal bone dissection.
Hmm.
I did only 5 in my life, but those 5 were completely in sync with looking into every bit of nerve when it starts and get it imprinted in your mind. and then develop your eye to see for the facial nerve before it comes. Before it comes.
Yeah.
And that happens, then we have an eye for that. Then you can always, and whenever there is a doubt that there is some facial nerve, many cases like iatrogenic or cholesteatoma itself, my CT will tell me somewhere the facial nerve is in, facial canal is affected or post-traumatic or iatrogenic. When there is a doubt in some area, don't disturb that. Go proximal and distal to that. Expose the facial nerve by drilling the fallopian canal. Create the plane there and then come towards the affected side. You are never going to do damage because you have created the right plane. Now, by following it with non this invasive instruments, you lift it with this elevator, tympanic elevator, or a gentle ball probe or something to create the right plane. Whatever lies lateral to it, could be fibrosis or disease, we can easily create the plane. And if the nerve is already injured, then we can do the repair. But going from both the sides and not attacking there. I always tell the students, whenever you are doing surgery, doubtful, when you are doing the lowering of facial ridge, there are cells. It gives a look of facial nerve only, that start bleeding. So consider every cell with mucosa to be facial nerve unless proved otherwise. When there is a cell located there and we don't know whether it is a nerve or not, again, drill around that soft tissue with a diamond bar. It will come out like an island, and suddenly you will see that this was just a cell, the nerve lies beneath it. Never do it directly. Don't poke the instruments there unless until we are sure. And take the biggest burr for that area.
Yep.
We are doing a facial nerve lowering or thinning. The biggest burr for that is not going to cause them trauma there. Don't take smaller burrs for that area. And another thing is run the burr in the direction of facial nerve always. And in single strokes. Don't do like just flowing like a brush of an artist. So that way, we are trying our best not to injure. And believe me, diamond burr, if rubbed nicely, never causes injury to the fallopian canal. Never causes injury. So I think that is the tips I can give.
Yes.
In case of Bell's palsy, should decompression always include the labyrinthine, or are there specific clinical indicators as just limiting? Okay. So, yes, labyrinthine should be either don't do the surgery. Either don't do, because honestly, when we do a surgery on Bell's palsy, usually the CT MRI may not show anything. May not show anything. There may not be some dehiscence, anything. But then labyrinthine segment should be included, and we can keep coming down wherever we find edema, go till that. Start from the labyrinthine segment only. That medial narrowing is very bad. So the meatal segment gets inflamed, edematous. That doesn't, exonoplasm supply is stopped. That causes suffocation. So doing it is no harm. That's why I want to teach you all the transzygomatic anterior approach, and we don't have to go to the middle cranial fossa approach, because labyrinthine segment, hardly how long is the nerve? Reaching there is just a small area of mastoid bone, but because it lies beyond the confines of mastoid, people are terrified of doing the decompression of labyrinthine segment. So I will show you the ways to reach the labyrinthine segment in one of the lectures. But yes, it should.
Okay.
Three Bell's palsy, then we must get a CT MRI to rule out any facial nerve neuroma or any other lesion other than the Bell's palsy.
Okay. So maybe the next one from the Dr. Devi Prativi.
Okay, the last, yes.
Yes.
And then she's thanking. Thank you very much. I feel honored, and I hope, because this was the first this thing, and it is the most difficult one, anatomy. Then after that things start becoming interesting. But I think if somebody tells us, then we remember it more. We all keep reading the things. So I just opened it and came across the topic of facial bifurcation, which can involve any of the segment. How frequent is this, and which segments are most common, and what are the surgical implications? These usually facial nerve anomalies are usually associated with extraocular canal and pinna anomalies also. So the patient starts giving you a hint when you see slightly smaller pinna, minimum. Extraordinary canal is slightly less. Then there can be stapes fixation. In those cases, you find a facial nerve away from its normal site. So many a cases I've seen, then it is mostly the tympanic segment and the second genu, it becomes slightly inferiorly and laterally placed. I have seen cases, I've operated on stapes cases where there was a bifurcation. It can be covering the oval window. Mostly that is the one which happens. Bifid is usually in the mastoid segment, usually. It can be in the tympanic and second genu also, but mostly in the mastoid segment. The tympanic segment can be either occluding the oval window or the stapes partially, completely, lying below the oval window, or bifurcating and the oval window lies between the two. So the easiest is when oval window lies between the bifurcated, you don't have to do anything, you can do surgery on the oval window. The half is also okay, we can slightly push it and place our things there. The worst is when it is completely occluding the this thing. So when we know by CT that it is occluding or it is downwardly placed, again always use a diamond bar there. I have made a second fenestra there, just inferior where it is anticipated oval window is, and we can do the stapes or ossiculoplasty through that part. Every situation is possible, but it should be conductive hearing loss. Then we shall go do all these things, taking risk for the facial nerve as well. So
Okay,
I
maybe
think
this is the last question. I think this is a very wonderful discussion and lecture from Dr. Mehta. I have a conclusion. Maybe just we should know the surgical anatomy so we understand how the disease develop, and we can choose the maybe in the technical or maybe in the approach of for the nephasia nerve that's approach. Maybe also know how long the nerve will cure, the function will come back, and we can
yes,
discuss with the patient before we
actually we can consult the
perform.
patient as well.
Yes,
Once we have
okay,
consulted, na,
yeah.
it is like, I tell you, if you've done a good work on facial nerve, na, more than patient, you are waiting. How it is improving. I keep calling, they are from different cities. They think this doctor is mad. That
Yes.
people don't give time. I keep calling them. Okay, send me the video. I teach them how to take the video. And slowly it builds up. It gives such a beautiful feeling that the face is recovering back.
Mm.
So every fiber of the nerve counts. Be very gentle as you are with the newly born baby.
Mm.
Wherever there is a sheath there, gone there, then replace it back. Don't be, in a hurry to do the surgery, to do any harm. There was a case I was operating in my fellows had come, so I given one case to that. So I was operating on the other. There are two tables. I found that he was drilling, 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 and drilling. The drilling was not ending, and the sound was not changing. It was hard. I felt
Mm.
something is wrong there. Your ears should be picking up the sound, how
Yes,
it's rubbing on the this
the
bony level,
bone.
how it is tegment plate, that tin-like sound of when this
Sure.
burr hits. So I went there. I said, just stop. I don't know how you are drilling and drilling, and you have yet not reached the antrum. I am really getting worried. I saw what he had done. There was a tympanosclerosis close to the this tegment tympani.
Mm.
So he took that tympanosclerotic plaque to be tegment bone and started drilling below it. The antrum was hidden. He was drilling through the lateral semicircular canal. He
Mm.
had injured the this sheath of the facial nerve. Lateral semicircular canal he had opened. Though this endosteum was not gone, the periosteum and everything bone was gone. So I stopped. I was in the worst of the forms. Then I took time, repaired the lateral semicircular canal. Then, though it was few, only sheath was gone, I decompressed the nerve on both the sides. Why? Because this nerve is going to react like anything because it has been injured, it is now angry. So, angry nerve will become facial nerve palsy grade 6. And
Mm.
if I don't do the decompression, it will be inflamed and take a very long time to recover.
Mm.
Once I have taken away the bony part, this got slightly settled. Now it will recover. And then that patient still took 2 to 3 months. Though only a sheath was gone, it can react very badly. So be gentle and use the right instruments. There is no hurry. One single case of facial nerve repair you've done nicely. It gives you a confidence of a lifetime.
Yeah. Okay, thank you, Dr. Mehta. Maybe Dr. Diana, you
Okay,
add
Diana?
something?
Okay, thank you very much. So I think we are very honored to have you here, and this is your books.
Thank you. Thank you
I
very
have
much. I
them.
hope you know what there are 5 books. One is I can when you call me to your this thing. One is on ossiculoplasty, which
Mm,
is the only book in the world only on ossicles.
Hmm.
Yes, and the other is cholecytoma volume 1 and 2.
mm,
The way we do cavity-less cholecytoma surgery, it is ultimate results. This is volume 1 is simple cases, volume 2 is when this cholecytoma is with complications. And
mm,
then another book is on lateral skull base with Dr. Narayan Jaishankar. So when I am coming up with the further better version of the ossiculoplasty now, different cases, different things. It has got 35 videos CD with it. So when I come over there sometime, I will definitely bring. Those are more practical. Well, I mean, I
Hmm.
like practical books. What I have learned over the years
Yeah.
has given me. It is not about just telling the theoretical part. More important is because every day we as surgeons are like very difficult life. We come across patients, we have to give good results, and the practical side is to be known better because those are not taught in the medical colleges. So it should be like every case we do, we should be knowing what we are doing. But I will love to give any. First, we will finish off the facial nerve, then I can give lecture on ossiculoplasty.
Yes.
That will be ultimate. So, how every case can be given good hearing if it is a conductive hearing loss? Every case.
Oh, see, that's very interesting.
Definitely. Very much.
So I think thank you very much, Dr. Mehta.
Dr. Diana.
Let me close this webinar. So the first program of the masterclass series of facial nerve has been conducted. We have received a wealth of qualified insight and basic knowledge of the anatomy that are very crucial for our practice. And for all participants, thank you for your participation. And we will prepare for the next lecture.
Dr. Diana,
Yes,
3 lectures are being taken in India.
yes.
On Gujarat, there is a webinar on 30th. So
Mm,
if you can, I will ask them, those 3 lectures include how to assess a facial nerve evaluation.
Yeah.
yes,
Second is post-traumatic. Third is iatrogenic facial palsy.
Hmm.
So these 3 lectures would be done. So I can connect you with that.
yes.
So 1.5 hours duration, 3 lectures will be covered. Then we
Okay.
can take the facial nerve and infections and go further. Can that be done?
We will discuss this with my
Okay.
team.
Okay.
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 So for all participants, thank you, and we will prepare for like Dr. Mehta said, there will be a next lecture about the facial nerve, and so also thank you very much from our team from Kodi Otologi, and once again thank you very
Thank
much.
you.
So we
Thank you,
will
Dr.
wait
Diana, for
for
giving me this honor.
your next lecture. Thank you
Thank you.
so much.
Thank you.
Thank you, Dr.
See you
Mehta.
all.
See
Wassalamualaikum
you.
warahmatullahi wabarakatuh.
Assalamualaikum.
Thank you. Bye bye. Thank you. See
Good
you.
night. Good night. Good night. Ji. Good night.
Bye.
Thank you, Dr. Dian.
Terima kasih.
Nggak
Terima
kasih
kasih.
foto Mbak Alin.
Terima kasih
Oh
ya
iya,
Dian.
lupa.
Terima kasih semuanya.
Makasih
Pakai konsennya.
semuanya.
Thank you, Dr. Dian, Dr.
Terima
Alin.
kasih.
Iya,
Makasih dok.
lupa.
Saya off
Thank
ya
you
dok.
semuanya.
Terima
Kita
kasih
bisa
semuanya.
berhenti.
Nanti
Terima
kita
kasih
omongin ya
semuanya.
yang
Ya,
next.
yang berikutnya. Termasuk yang ossiculoplasty tadi bagus tuh. Nanti di
Iya,
match sama Om Caca aja.
dan tadi dia sudah menyiapkan 3 lecture lagi ke depan.
Yang untuk ini ya, facial nerve ya.
Stop dulu.
Oke,
Jadi
nanti
kita
kita
coba
Karena bisa di
kombinasikan ya.
stop.
Kenapa gimana, Di?
Bukan saya dok.
Oh, bukan.
Ini Dokter Artono. Mungkin kena gonjangan terbangun sebentar ya, ngomong kan.
Oke, terima kasih semuanya.
Terima kasih
Kita
semuanya.
koordinasikan ya.
Terima kasih.
Ya, terima kasih
Sehat
dok.